Okay, I guess I'll talk for you. Good morning, everybody. Thank you very much to the committee for the invite to participate in this conference. My name is Talal Al-Qaoud. I'm a transplant surgeon and urologist. I originally trained as a urologist, and then I completed training in multi-organ transplant and practiced as a multi-organ transplant surgeon. I work at Al Amiri Urology Unit in Hamd Al Isa Organ Transplant Center in Kuwait. So I have no conflicts of interest to declare. I will jump right into the talk. I'm going to talk to you about considerations for the transplant patient regarding the upper and lower tract. And then I'm going to talk about the update with respect to wait times with respect to the urologic cancers. So it all starts in the clinic. You're going to see the patient is the transplanter. You want to determine the history of the end-stage renal disease or CKD, how long the patient's been suffering. Are they on dialysis or not? Are they making urine? What kind of access do they have? Vascular or PD? Have they had a transplant before? And you want to probe their past medical history because a lot of those diseases will prompt you to think about any underlying urologic problems. So any congenital anomalies, diabetes is a big one in this part of the world. Diabetes can lead to a lot of lower tract symptoms as well. You want to figure out the support system of the patient, whether this patient is going to have a successful outcome or not. And obviously, you would examine the patient and look at their imaging and proceed from there. You obviously want to make sure you're not transplanting somebody who has a reversible kidney disease, and you want to rule out the big no-nos before you proceed with your blessings from a surgical standpoint. For those in the audience who are not involved with transplant, so in kidney transplantation, in the contemporary era of kidney transplant, if you have a straightforward transplant to do, you would transplant the renal vein onto the external iliac vein and the renal artery onto the external iliac artery, and obviously the ureter onto the bladder. You will have other scenarios such as multiple arteries on a Carrel patch, which you would anastomose as a patch onto the iliac system. This kidney does have a vein, but it's not deficit here. Historically, a lot of patients had their renal artery anastomosed to their internal iliac system. This has been abandoned because of the issues with potency for men mainly. And like I said, conventionally, it's onto the external iliac system. If you have a pediatric patient or a retransplant, you would want to anastomose your vessels onto the distal aorta and vena cava to improve the inflow into the kidney, and if you don't really have room to anastomose down in a retransplant patient. Sometimes you're faced with a deceased donor with marginal kidney function, and you will definitely not have a good outcome if you transplant a solitary kidney. So you would proceed with doing a dual transplant, which is, as you can see, one kidney is on the vena cava and aorta, and the other one is on the iliac system. Of pertinence here is that you want to think about how you're going to do your urethral anastomoses so that if you develop any problems down the line, then you can access each unit's ureter separately. There are sad cases where you have pediatric donors, and unfortunately, this will continue to happen. And as our colleague from Dr. Al-Zahrani showed, the list for kidney transplant and the wait list is growing; it's not shrinking. So there will be instances where you have pediatric donors, and in donors less than 15 kilograms, you usually would use the kidneys en bloc, and you would transplant them onto an adult or an older kid, and they come with the vena cava and aorta from the donor, and you anastomose that to your iliac system. Depending where you are in the world, you may get called in as the urologist by the transplant team because the patient has an ileal conduit, and you're asked to do the ureteroileal anastomosis. So most of the time, that kidney is transplanted actually upside down so that the ureter can take a more straight course into the conduit. Um, I'm going to talk briefly about pancreas transplant because historically, and there is a surplus of these patients from certain centers where the pancreas transplant is transplanted onto the bladder, and I'll show you in a second. But this is the conventional contemporary way. So the pancreas transplant is performed onto the right side of the abdomen, and it's enterically drained, no longer bladder drained, and the kidney is usually transplanted on the left side. Historically, and in certain centers of the world, as you can see on the right-hand side of the diagram here, the duodenal bulb, which is the exocrine drainage of the pancreas transplant, was anastomosed onto the bladder. And historically, these patients would have a lot of urinary tract symptoms, urethral strictures, hematuria. So that's been abandoned over the last decade, and most of the transplants are performed, like I said, enterically drained rather than bladder drained for the exocrine function. So let's move on to the urologist's role here. So as the urologist involved, why is it important to be part of the transplant team? It's because if you think about it, a lot of the renal disease in kids is urologic in nature or urologic in etiology. In adults, it's a smaller percentage, but a lot of the transplant patients, whether it's for kidney, liver, pancreas, heart, lung, all of these patients will have a lot of comorbidities, which include urologic causes. So if we focus on the kidney transplant patients now, what is the urologic cause? Is it the kidneys, the ureters? Is it the lower tract? You want to probe in the history whether these patients have recurrent infections, unresolved chronic bacteriuria, stones, incontinence, and uresis. So all of that should be in the back of your mindset when you have a referral to see a patient in preparation for transplant. So if we focus on the upper tract first, so the most important one, I think, for the urologist in a center where there's transplant service is you'll get a patient sent to you for a question about whether this kidney needs to come out. And we're not going to exhaust the list of what are the indications for pre-transplant nephrectomy, but most of the time you'll get a patient with a small renal mass, or somebody on dialysis, or somebody with high-grade reflux, or somebody with stones, or somebody with polycystic kidney disease. So these are valid consults that you need to think about. So when you have a patient who has a problem, you want to know if this patient is going to get transplanted anytime soon. So timing of the nephrectomy is important. Somebody who's just been on the wait list, who's going to wait another 3 to 5 years to get a kidney transplant, who's making urine, and the issue is not really that urgent, you may want to delay the intervention until this patient has a clearer idea if they have a living donor or this patient is going to get transplanted soon or not. So the things you want to think about are, does he make urine? Any issues with dialysis with respect to blood pressure? Because, you know, the kidneys aren't making urine and they're not making EPO, but the kidneys are secreting renin. So these patients are having blood pressure issues during dialysis. You want to also think about whether I want to take this kidney out for a benign cause or not. And obviously, it's important because if you have a living donor and you have a really small renal mass, as we're going to talk shortly, you can wait until you get transplanted for us to deal with it, or to deal with it at the time of transplant. So, is pre-transplant nephrectomy in patients with chronic kidney disease a wise decision for cancer? And the answer is yes and no. So, if you look at this cohort of patients from multiple centers, so this is nearly 50,000 patients, and 2% of those patients had CKD, and they underwent either open or radical or open partial, or lap radical or partial. And it is not a walk in the park for these patients because they have a higher chance of post-operative complications, post-operative morbidity, and most importantly, their hazard ratio for mortality is 4 times those individuals with no CKD. So the take-home message here is not every patient with a renal mass on a dialysis, or sorry, on a transplant wait list needs to be managed promptly. We have to be wise. And why is that? Because if you look at the data in patients who are not with organ failure and with small renal masses, the risk of them metastasizing is extremely low. And this is again from a large cohort of patients from Memorial Sloan Kettering, a large cancer center in the US. The risk of metastasizing is basically in a T1A lesion, for instance, is less than 2%, less than 3%. So you're not going to all of a sudden have a patient in 3 months with mets all over the place if they come to your office for a pre-transplant nephrectomy. Why is active surveillance of these patients attractive? Because we know from non-transplant patients and not organ failure patients that you can put patients on active surveillance with a small renal mass. The growth rate is low, especially if we're talking about the elderly patients. And in CKD patients, most of which have multiple comorbidities, you're going to have an aging population, so a lot of these patients are elderly as well. You would want to conserve until the appropriate time comes for you to intervene, especially if you have a patient who needs a heart transplant. So let's say a patient's in the ICU or in the CCU awaiting to get a heart transplant, and they do a CT and there's a small renal mass. Are you going to jump on this and take care of it before transplant just because there's theoretically an increased risk with immunosuppression? And the answer is no, you don't need to. And you can conserve and then manage it later. So if you surveyed centers in your part of the world, so this was a survey in the US about transplant centers, whether surgeons were comfortable transplanting patients who have renal masses if they were on active surveillance. And the survey showed that although most of these patients are managed by radical nephrectomy or by partial nephrectomy or focal ablative therapy, which is an intervention here, there was still a good 20% of centers doing active surveillance for such of these patients. And when they surveyed these surgeons, the majority actually, that if they were presented with long-term data on active surveillance in these patients, they would actually survey these patients, get them transplanted, and then definitively manage the renal mass. So the take-home message here is that not everybody with a renal mass should have a pre-transplant nephrectomy, but after you transplant these patients, you have to definitively manage the renal mass because we don't have data on active surveillance in this patient population. So that's the first take-home message. 2 is that you have to be wise and think about the whole picture, not just the renal tumor in this patient who comes to you in the clinic. There is an associated morbidity and mortality that we have to be very wary of. So we move on to patients who have stones. So does every patient with stones need an intervention before transplant? Again, the answer is no. So patients that have staghorn stones, yes, this probably should be managed before transplant if it's feasible and you can do a nephrectomy on this patient, because they will most likely develop problems post-transplant related to infectious disease. Patients who have acquired cystic kidney disease. So acquired cystic kidney disease, the longer you are on dialysis, as you know, the more likely you're going to develop renal cystic disease. And the more renal cystic disease you have, the more likely you will develop RCC. And then we go into this vicious cycle again. Do these patients need nephrectomy pre-transplant or not? What is not standardized in this patient population is surveillance of these patients when they have cystic renal disease. Do you survey them like the general population according to Bosniak classification, or do you treat them differently? And the answer is uncertain at this point. But basically, by 5 years, 50% of your patients, by 5 years on dialysis, 50% of your patients will develop cystic renal disease. Autosomal dominant polycystic kidney disease. So it's the leading hereditary cause of end-stage renal disease. And around 50% of these patients will develop renal failure and go on to dialysis and require a transplant. The indications for nephrectomy here, pain, is one, early satiety, size, obviously concern for malignancy is another one. The important take-home message here is that there are studies that have looked at the timing of nephrectomy for polycystic kidney disease. I think I didn't put that slide up. But anyway, there was a big multi-institutional study that looked at that. And if you do it pre-transplant, your concern is to give blood products and develop donor-specific antibodies in the future. If you do it simultaneously at the time of transplant, then there is a slightly higher risk of developing delayed graft function of the graft and venothrombotic events. And if you do it after transplant, then that really has the lowest risk. So think wisely. If you can place the kidney in the retroperitoneum without needing to take those kidneys out at the time of transplant or before, then it's the best timing is probably to do it after transplant when these patients have normal renal function, that increased morbidity associated with CKD is eliminated and it's off the table. Patients with hydronephrosis and reflux, you will get to see a lot of these patients that come to your clinic. And if you have hydronephrosis with no clear cause, there's no underlying malignancy, then you really need to think about the lower tract here. It's not really the upper tract. There's a problem in the upper tract, but it's secondary to a problem in the lower tract. So that's where you need to focus on most. This is a rare scenario, but patients that have antiglomerular basement membrane disease with good pastures, for instance, these patients will benefit from a nephrectomy or angioembolization because they tend to lose a lot of protein in the urine, and they're at a hypercoagulable state, which you don't really want after your transplant. Renovascular hypertension. So patients, again, this is rare because the majority of your patients that do have renovascular hypertension have atherosclerotic disease of the aorta. And these patients, really trying to intervene on them will not change their course of disease. But if you have young patients that have intimal fibrodysplasia, then these patients will benefit from a nephrectomy for you to optimize their blood pressure control after transplant. I'm not going to talk a lot about the lower tract since the conference is mainly about the upper tract, but I just want to make one point clear. A lot of the disciplines we work with think the bladder is a balloon and you just fill it and it empties, and that's not the case. It's actually a very evil organ, the bladder. It works sometimes in mysterious ways. So there's a lot of data looking at defunctionalized bladders, biopsying these bladders, trying to cycle these bladders pre and post-transplant. Really, a lot of the patients you will see are oligoanuric, so it's difficult to gauge if they truly have underlying lower tract symptoms or if they truly have underlying bladder disease. So to simplify it, basically, who needs a lower tract assessment? Anybody with LUTS needs a lower tract assessment prior to transplant. You don't necessarily have to go the whole 9 yards and do a urodynamics and all that. No, think most of the specialists in the field would say a uroflowmetry if they're making urine, and then proceed from there with a VCUG if you need to, should be your basic workup. But in patients who are not making urine, if they don't have a underlying neurologic disorder, and if they're not diabetic, you really don't need to go through the whole workup. But anybody who has a neurologic underlying disease, and especially diabetic patients, because we live in parts of the world that have, for instance, here in Kuwait, 40% of our population is diabetic. And it's very clear what the effects of diabetes are on bladder function. So you need to think about those patients very closely. And then in those patients who are oligoanuric, you don't really necessarily need to think it's a hostile bladder because they're not making urine and they've been anuric for 5 years or so. That's not the case. Most studies that have been done early on, even not recently, a lot of these patients, even with a walnut bladder of 30, 50 ml capacity, will develop better capacity with time once they start making urine with the transplant and whatnot. So a hostile bladder is a bladder you should think about when there's an underlying neurologic abnormality or maybe diabetes, but otherwise you should treat these patients like any other patients. So let's move on to the last part, which I felt was important to talk about, because this has been evolving and changing. Historically, every cancer has to wait at least 2 years, and some cancers have to wait for 5 years. However, as more and more understanding of tumor biology and how disease recurrence patterns are, things have changed over the past decade. So during my time in the US, I was fortunate to work with a group that put together a consensus to look at different cancers and the waiting times and candidacy for transplantation. So I worked with 2 other urologists from the University of Chicago, and we looked at the updated data and all the recurrence patterns for the last 2 decades. And really, when you want to transplant somebody with a malignancy, you need to put into mind multiple factors. First, there's the cancer biology, tumor biology factors that you have to factor, obviously, patient factors, the effects of immunosuppression, and you want to understand the plot here. If you're in somewhere where there's not a lot of organ supply and there's a lot of organ demand, then the picture is a little bit different compared to somewhere where there is a good donor pool and there is readily available donors and there is a surplus of organs. So let's talk about prostate cancer. As we all know, it's very common. If you look at autopsy data, up to 50% of males will have prostate cancer in their mid-50s. Obviously, it's skewed for African Americans, but even Caucasians, it's a highly prevalent disease. So you will ultimately transplant patients that have prostate cancer or harbor prostate cancer. So why wouldn't you transplant them if they have prostate cancer that's been newly diagnosed? And let's look at the data for that. So if you look at PSA screening in kidney transplant candidates, and this is from multiple centers in the US, you see that amongst nearly 4,000 men, of which 60% underwent PSA screening and the rest didn't. And if you compare those patients in terms of patient survival, graft survival, and cancer-specific survival, there's no difference. The only difference is that if you had screening, you probably got delayed to transplant, you had longer wait time, you were less likely to get transplanted. So all of this is disadvantaging the patient for no reason. So does the immunosuppression affect your outcomes of prostate cancer? And the answer is no, it does not. So immunosuppression so if you look at patients who were transplanted and patients that were not transplanted and had prostate cancer, and you look at their 10-year cancer-specific survival, so if you put these patients on immunosuppression, are they any worse than patients that are not on immunosuppression? And the answer is no, it does not impact their 10-year cancer-specific survival. Prostate cancer post-transplant is not at an increased risk. So the standardized incidence ratio is 0.92, and this is from a large cohort. This is a US registry of 175,000 solid organ transplant patients, and immunosuppression and transplant does not increase your risk of prostate cancer. If anything, it's actually slightly lower. So the take-home message is diagnosing somebody with prostate cancer during any time of a transplant evaluation process should not really delay or influence your decision to transplant this patient unless this patient has metastatic castrate-resistant prostate cancer. So this was an update of the wait time. And as you can see here, for very low-risk patients and for low-risk patients, whether you actively survey them or you treat them, you don't have to wait for transplant. You can proceed. Even for low-volume intermediate risk and for high-risk disease, if you plug their data into the MSK nomogram and they have a cancer-specific mortality less than 10%, you can proceed with transplanting these patients. These patients are not going to die from prostate cancer. Really, at this point of time, the only patient you should not even consider transplanting is metastatic castrate-resistant. Because metastatic castrate sensitive, if they have stable disease for 2 years, then they're unlikely to flare up in the next 4 or 5 years. Then you can transplant these patients, especially if they have a living donor and they understand the risks associated with that. So if we moved on to renal cancer, again, just plugging back to what I was saying earlier, most of the small renal tumors have an indolent behavior. If you look at the data again from a Mayo Clinic, large cohort of patients who underwent, again, this isn't transplant patients, but this is solid data. If you look at the 10-year cancer-specific survival for these small renal masses, it's above 96%, and the recurrence rates are low, which I'll show you shortly in the table. But if you have a small renal mass, a T1A, low grade, why do you have to wait for transplant? You don't have to wait for transplant anymore. Again, this is all oncology literature. Thank you. The thing that's important and to remember is that patients that do have a history of renal cancer are unfortunately at a slightly higher risk of graft failure. And that's really not related to the cancer itself. It's really related to the shift of the immunosuppression. So there's no standardized regime to change immunosuppression. It's center dependent, but it does have a negative impact on kidney graft survival. So if we look at the recommendations for T1A or T1B, low grade, you don't need to wait anymore because the recurrence rates are low in the first 2 years. So you don't need to wait. You can proceed with transplant. For T2 and above, you have to wait at least for 2 years because most of the recurrences occur in the first 18 months after resection. Obviously, for the aggressive histology, they're not really a solid organ transplant candidate at this point. I'm going to try and whiz through bladder because I have less than 5 minutes to go. So if you look at bladder cancer, again, it's stratified to low, intermediate, and high risk. So if you look at the European data from the aortic trials, for low risk, non-muscle invasive bladder cancer, if there's no recurrence in the first 6 months, the risk of recurrence at 24 months is low and progression is low. So if in the first 24 months, they're not going to progress or recur based on no recurrence in the first 6 months, and this is large European data, then the recommendation can be you can wait for 6 months, and then if they don't recur in the first 6 months, then you can list them for transplant because they're unlikely to recur in the following period. And it's very similar for intermediate risk. Again, they're not all one size fits all. You have to think of this case by case. But if they don't recur in the first 6 months, then you don't need to worry that much if they have a living donor and they understand the risks and they want to proceed with transplant. Obviously, for high risk, non-muscle invasive, you want to be very cautious and wait for 2 years. So that rule still holds. For radical cystectomy patients, again, that rule of 2 years still holds because most of the recurrences occur in the first 2 years. For trimodal therapy, they're not really solid organ transplant candidates at this point. And that's it. And thank you very much for listening.
Thank you, Talal. We'll keep that questions in the end.